Okay, thanks everyone for joining today. We were just discussing a couple new faces, or I guess names that we saw in the chat. So glad to have you along today. I will be presenting a brief session today on a couple of the clinical controversies slash updates in the world of diabetic foot infection and diabetic foot osteomyelitis, since it's part of our topic for this month. So I will go ahead and get started. Objectives today are going to briefly review updated recommendations for treatment duration in certain cases of diabetic foot infection osteomyelitis, and to recognize and discuss the role of anti-pseudomonal agents for empiric treatment of diabetic foot infection. To begin with, I just wanted to pull a couple of statements from the most recent IDSA update on diabetic foot-related infection, which was published in 2023. And the first of those updates were their statement regarding empiric anti-pseudomonal therapy. So the expert consensus published in that guideline update was to not empirically target antibiotic therapy against Pseudomonas aeruginosa in cases of DFI in temperate climates, like that here in West Virginia, where we're presenting from, but to use empiric treatment of Pseudomonas if it's been isolated from cultures of the affected site within the previous few weeks, or in a person with moderate or severe infection who resides in Asia or North Africa, where epidemiologic studies have shown more frequent isolation of not only Pseudomonas aeruginosa, but a number of other gram-negative organisms as well. With that in mind, I wanted to dive a little bit deeper into why this recommendation was the way it was. So an article cited by the consensus expert group in the guideline was that published by McDonald and colleagues in 2021. It was an epidemiological study that wanted to investigate the prevalence of different bacteria isolated from diabetic foot infections. They included any study of any design. It could have been retrospective, prospective, and ultimately included 197 publications in their analysis, comprising over 16,000 patients, and looked at over 22,000 different microbial isolates. Of note, the type of culture was not necessarily differentiated in this study, so it could have been a superficial wound culture, it could have been a deep bone culture. There was a lot of variability in what isolates were included. They excluded studies that had less than 10 patients to prevent issues of bias or selection bias. So any study that was included looked at least 10 patients with DFI. If they were paywalled or not readily immediately available in full, they were excluded, and those without publication in the English language or an available English language translation were also excluded. This study was published in a British infectious diseases journal. Ultimately, what the authors found was that the most prevalent organisms in their study, in order of sheer numbers across all those isolates I mentioned earlier, were Staphylococcus aureus, including both MSSA and MRSA, E. coli, and third were Pseudomonas species. Of note here, and I think gives some credence to the recommendation provided by the experts, gram-positives, including Staph aureus and strep species, were far more likely to be isolated in high-income countries. And that definition of high versus middle versus low income are based on those definitions and categorizations provided by the World Bank. So they essentially looked at every study and what population was examined in what country or region of the world, and determined that gram-positive isolates were more likely to be isolated in high-income countries, and that gram-negative isolates, including Pseudomonas aeruginosa, were more prevalently and frequently isolated in upper middle or lower middle income countries. So with that in mind, with the recommendation I reviewed in mind, when do you empirically start anti-pseudomonal therapy for diabetic foot infection? I think there's probably a wide array of practice that I've observed and seen. feel free to throw an answer in the chat or briefly unmute.
I've found my practice change over the years. And I think right out of fellowship, I was a bit too gung-ho about covering having anti-pseudomonal coverage. More recently, I think, moved away from covering the pseud. Even when it tends to be isolated, I think of it more as an epiphenomenon selected out by the antibiotics I'm using rather than a true pathogen. Because sometimes these patients are getting better on regimens that don't cover pseud. So I feel like that's been kind of an evolution over time for me personally. So the answer here would be probably not
Not often.
90% of cases.
I agree. I still, every once in a while though, will find myself like, should I have covered pseud, especially the outpatient setting for more mild to moderate diabetic foot infections. I found moxifloxacin to be great, as your anaerobes, but it doesn't cover pseud. My general practice is to get a MRSA swab. If negative, just do moxifloxacin, but agree. For some reason, it still kind of catches me if at that like 1 week follow-up, it's still not like,
Getting better.
yes, it's always in the back of my mind, could it be Pseudomonas? Although that being said, most of the patients I've taken care of have done well without it. Yeah.
No, something you had said, John. Regarding the guidelines published that I mentioned earlier, I mean, that is a strategy they advocated for, especially in like outpatient setting and mild to moderate infections, where we can start without pseudomonal coverage, and if they aren't getting better, it's not in the, I mean, maybe the scenario is a little bit different if they're septic in the emergency department.
Yeah.
Therapy. Anyone else? Well, I don't see any chat alerts, so I'll go ahead and move on. The other thing that was presented here, based on some findings in the preceding years, was a consideration of a shorter duration of therapy after minor amputation for diabetes-related osteomyelitis or DFO. In those patients, with compared to a 6-week, consideration of treatment course in patients without any sort of bone resection or amputation. So they're essentially saying in those who've underwent either a partial resection or amputation, maybe some debridement, they even mentioned partial calcectomy of the heel. In some cases, if a infection is not exclusively isolated in the toe, could be considered to treat for 3 weeks instead of a longer 4 to 6 week course. And the primary study they cite in that recommendation was a pilot trial by Giriani and colleagues published in 2021 in Clinical Infectious Diseases that looked to compare outcomes of 3 weeks versus 6 weeks of systemic antimicrobial therapy in patients with diabetic foot osteomyelitis who underwent some sort of surgical debridement. So they included patients who were at least 18 years of age, had undergone appropriate debridement of all necrotic tissue of the diabetic foot wound or infection, excluded patients who had any implant-associated infection. So if hardware was involved, they didn't include them in their pilot study. If they had total amputation of all the infected tissue, they weren't included. Could probably even get away with much shorter duration of therapy after full amputation in those patients. And regarding their inclusion of partial surgical amputation, that definition they admit was pretty loose. That could be amputation of a single toe, but maybe leaving another toe that was involved that wasn't surgically removed. They would consider to include and randomize under 3 versus 6 weeks. And like I mentioned earlier, partial calcanectomy was also considered partial amputation, partial resection. So ultimately what they found in the 93 patients that were randomized to the two different groups, where that clinical remission occurred in 84% of patients in the shorter duration arm versus 73% in the longer duration arm. That was a non-inferior, non-statistically significant difference. And so they ultimately concluded that clinical remission could be achieved in this patient population with a shorter duration of therapy versus the longer duration of therapy. Just a couple of baseline characteristics on the study population, since I think it's important to consider, or at least be aware of. Staph aureus, either MSSA or MRSA, were isolated in about 50% of all patients. Any gram-negative bacteria in about 25% of their patients, and polymicrobial growth in cultures at around half of their patients. So I would say pretty consistent with what we see in cultures collected in DFO and DFI. In terms of, were there any variables that affected clinical remission or failure? All those that they looked at, including they looked at just osteomyelitis due to Staph aureus, those who had underwent their definition of partial amputation versus just more so superficial debridement. There was no impact in clinical failure or clinical remission. Granted, this was a study that included 93 patients. And similar rates of adverse effects were reported amongst both groups as well. But I think it highlights this in the guidance document an opportunity to consider in those, even with partial source control, a shorter duration of treatment in those with diabetic foot osteomyelitis. So with that in mind, what duration do you commonly find yourself either prescribing or recommending in DFO when you have partial source control or partial amputation? Would like to pose that to the listeners on today.
I see 6 weeks a lot, honestly.
Yeah, that's, I mean, I think historically has been what, obviously that's why they've looked at studies for shorter duration. 6 weeks kind of was just the standard for a long time.
They have an IND for partial source control. Like you said, 3 weeks, but 3 to 4 for using CRP.
I like this study. It might be because I'm married to a surgeon, but I feel like it's a good study that takes a surgical and a medical combination. I know when it first came out, or when I would be reviewing patients and we'd be doing 6 weeks because maybe there was another toe with osteo that wasn't debrided, I'd be like, well, we have to treat that for 6 weeks. And looking back on it, and reviewing that paper, I think what I should have been thinking was, well, why didn't a surgeon debride that toe when the patient was back there?
Right.
Yeah, under anesthesia. And instead, I should have been using their clinical judgment of how significant that infection or active that infection was. I think for my patients, I find the most pushback sometimes when I try and decrease their duration, more so than when I'm talking about adjusting antibiotics from IV to PO. But I don't know if that's maybe because my practice, I'm still somewhat early, was IV, now IV to PO, so I feel more comfortable with that conversation, but maybe duration, I'm not having the best conversation. I'm not sure. Yeah.
I think this also is best looked at in terms of historical perspective. It is an accurate statement that in infectious diseases in general, we have lent towards overtreatment for prolonged durations, and are only now beginning to see shorter is better. And to me, this is just another study that adds to it. And it's quite remarkable how much literature there now is saying that shorter is better as compared to longer is better. It's almost like 90-10. There are very, very few things that need the traditional prolonged durations that we've been given. my own approach for partial source control has been, okay, debrided bone is mostly been removed. Most of what we are dealing with is probably skin soft tissue. So start at 2 weeks, go till 3 weeks, and at maximum stop at 4. So I found myself doing less and less of the reflexive 6 weeks for any osteo, even if it's partially sourced. By the way, blood supply makes a big difference.
Mhm.
If you don't have adequate blood supply to bone, it doesn't matter whether you give 6 weeks or 4 weeks.
Meant to mention that I think about 60% of these patients had some sort of peripheral arterial disease. That is all I have. My references from study to or guidelines and studies today. Appreciate the opportunity as always and the discussion here. I will stop sharing my screen.
One more comment about this diabetic foot infection guidance. I think the other highlight was this is a disease that lends itself to a multidisciplinary approach. Not only do you need ID, not only do you need wound care, but you also need vascular surgery, you need podiatry. And I think, we're beginning to learn more and more that our patients do better when we all kind of sit and discuss the best approach to them from different perspectives. So I think this is another one of those diseases. And the second point was, I've seen a shift towards diabetic foot infection should probably be, by default, started off with oral agents. Initially, there used to be a push for start with IV and then come to PO, but slowly I'm beginning to realize, and maybe this is a testament to all the oral therapeutics we now have, Moxie and others, that more patients are being treated with oral agents now.